Hello, my name is Regis Paulinelli and I'm a breast surgeon and oncoplastic surgeon from Brazil. I would like to extend my gratitude to Dr. Carlos Alberto dos Santos for inviting me to this webinar. It's a pleasure to be here with you. 2 years ago I had the wonderful opportunity to visit your beautiful country with my family during our vacation. It was really amazing. Today, Dr. Dusan has asked me to discuss breast cancer surgery and breast reconstruction. Dr. Dusan asked me to make this presentation interesting not only for breast and plastic surgeons, but also for hospital staffs, nurses, and other medical specialists. I'll try to make it easy to understand, but also comprehensive and up-to-date to try to be interesting for everybody. Let's see if I can reach this goal. There will be around 2.3 million breast cancers in 2023, according to World Health Organization. Breast cancer is the leading cause of death in most countries, including Brazil and Europe, especially among women. The future burden of breast cancer is predicted to increase to over 3 million new cases and 1 million deaths in 2040. Reducing breast cancer incidence is called primary prevention. This way we could prevent some breast cancer cases to occur. There are many risk factors for breast cancer. Some of them we can't change, like being a woman. Women have 100 times more breast cancer than men. Incidence rates increase with age. Breast cancer is 6 times more common after 50 years old than before. We expect as population increase in age, we expect this population to grow older and to have more breast cancer, and so I think it will be more severe in the future, the incidence of breast cancer. Family history is also important, and some cancers may be caused by pathogenic genetic mutations, like those occurring in the BRCA1 and BRCA2 genes. But everyone should be cautious about breast cancers. 70% of breast cancers occurs in women without family history. In Brazil, 1 in 10 women will get breast cancer. In Sweden, 1 in 8 women will have breast cancer. Hormone factors are important. More exposition to female hormones is related to more cases of breast cancer. So, early menarche, late menopause, prolonged hormone therapy, for example, could increase breast cancer risk. Breast cells differentiate with pregnancy and breastfeeding. So, women without children or getting pregnant after 30 years old are more susceptible to breast cancer. There are some premalignant breast lesions that work as marker for breast cancer risk and as atypical hyperplasia. We still can't change our age, our genetics, family history, or the age at the first period. Women nowadays have fewer children and delay the age at first birth. But if we change lifestyle, up to 68% of breast cancers could be prevented. Preventing obesity is mandatory. We could reduce 32% of breast cancer this way. Obese women produce more female hormones and in fat because of an enzyme called aromatase. We can stimulate physical activity and breastfeeding. Alcohol intake is also related to breast cancer. It's also well established that a healthy diet rich of vegetables and fibers can reduce breast cancer. If we are able to identify high-risk women based on family history and genetics, we could also use medicines like tamoxifen to reduce breast cancer incidence. For some women with pathogenic mutations, there is a possibility of risk-reducing surgery like oophorectomy and mastectomy. But as I said, 70% of breast cancers don't have any family history. A high-risk genetic mutation will be found in just 10% of breast cancers. Early diagnosis or secondary prevention is very important. Here you can see the survival curves according to the stage of the disease in 10 years. If we find in situ carcinomas before they invade the tissues, 98% of the women will be cured with surgery alone. And the mortality rates increase with tumor size and lymph node involvement. Unfortunately, in the case of metastasis, most women will be dead in 10 years. So early diagnosis is important in reducing mortality and preventing more aggressive treatments. Here you can see the results of the most important screening studies using mammography. In the 70s and 80s, some randomized studies were conducted, some in Sweden. At this time, researchers randomized if the woman would get a mammogram or not. It was ethic at that time because we still didn't know the real benefit of breast cancer screening program. Almost all studies show the great benefit of biennial mammograms after 40 years old and especially after 50s. On average, there was a 25% mortality reduction in the screening group. It's important to know that ultrasound and MRI doesn't replace mammography. They can't find other missing cases of breast cancer, especially in women with advanced breasts, but they increase cost and distress because they find many suspicious benign lesions that will need biopsy at the end, causes stress to the patients. Both ultrasound and MRI have high false positive rates. I don't believe we will have new randomized studies. It would be unethical nowadays. We already know the importance of mammography screening programs. This recent Swedish prospective study with more than 500,000 women showed a great survival benefit in serial participants of the Swedish screening program in comparison to those less adherent that would skip the mammogram sometimes, and much more in serial non-participants. Serial participants had 50% less risk of dying in 10 years than non-participants. There are different histological types of breast cancer. Initially, precursor lesions may appear, such as benign proliferative lesions known as B3. That increase the risk of breast cancer. Don't mix B3 lesions with the BI-RADS category 3. It's another thing. We're talking about a kind of lesion, not the classification, the BI-RADS classification. Then there will be the development of the new in situ carcinomas and finally invasive carcinomas. In situ carcinomas are limited by the basement membrane and have no capacity to cause death. Not all in situ carcinomas will become an invasive lesion. When carcinoma becomes invasive, it can infiltrate tissue, blood vessels, and lymphatics, and ultimately metastasize to other organs and cause death. Breast cancer cure depends on early diagnosis, quick access to breast surgeon or breast oncologist, and adequate treatment. Much money is being spent on chemotherapy and new drugs. It's very important, especially for locally advanced breast cancer, but 80% of breast cancers will be cured because of surgery. Hormone therapy will cure 10% of the cases, another 10% will be cured because of chemotherapy and radiotherapy. It's very important that any women with breast cancer have a quick access to treatment. Delays in starting treatment of more than 2 months are related to increased mortality. There are different breast cancer molecular subtypes. Luminal tumors are the most common, express hormone receptors, are sensitive to female hormones such as estrogen and progesterone. These tumors are less aggressive and tend to have recurrences and metastases later. Small tumors, luminal tumors, up to 1 or 2 centimeters, usually do not need chemotherapy and are treated with hormonal drugs. Luminal tumors larger than 5 centimeters require chemotherapy treatment. And these treatments are usually done before surgery. They are called neoadjuvant chemotherapy. For luminal tumors between 1 and 5 centimeters, there are genomic tests such as Oncotype DX or MammaPrint, which can tell which tumors should benefit from chemotherapy, and we can avoid these more aggressive treatments for less aggressive tumors or for those which do not respond to these treatments. HER2 tumors express this kind of protein, which has been the target of several new drugs, which has greatly increased the chances of cure. HER2 tumors larger than 1 centimeter require chemotherapy, and those larger than 2 or 3 centimeters require neoadjuvant chemotherapy. Triple negative tumors are usually the most aggressive. They have been the subject of much research to discover possible therapeutic targets and new drugs, but they still have a darker prognosis. Even tumors up to 5 millimeters require chemotherapy, and tumors larger than 1 centimeter require neoadjuvant chemotherapy. And I'll give you some idea of how breast cancer surgical treatment is. As I said, surgery is responsible for 80% of cures. But we don't need to be too aggressive. We have enough level 1 evidence to say that conservative treatment is equivalent to mastectomy. Here you may see 6 big randomized trials. Local recurrence and survival were similar in quadrantectomy and mastectomy. Sentinel node biopsies nowadays replaced many indications for axillary clearance, and it's fantastic achievement because there is much less morbidity like lymphedema and shoulder disabilities. There was an increase in bilateral mastectomies in the last decade because of fear, but for most women, the risk of contralateral breast cancer is low. A bilateral mastectomy doesn't impact cure or survival. Breast reconstruction is not the same as the natural breast. There is a much higher risk of complication and dissatisfaction. It's important that women and doctors be aware of it. For tumors larger than 5 centimeters, multifocal or multicentric tumors, there isn't level 1 evidence. But we are about to publish a meta-analysis with level 2 and level 3 studies. There is a high risk of local recurrence in the case of conservative treatment. It's the same as for small tumors. It's not an increased risk. I think it will work the same way. But the overall survival is similar. So it seems to be a safe option. Conservative treatment seems to work as well for small tumors as for locally advanced breast cancer and multicentric tumors. Why it's important to try conservative treatments in such difficult cases? Wouldn't it be better or easier to have a mastectomy? We are creating a database of our patients who have completed all stages of breast reconstruction and have returned after at least 6 months of surgery and radiation therapy. In this partial analysis of 760 patients, partial breast reconstruction, i.e. oncoplasty, led to much better satisfaction using BreastQ, much fewer complications with the same local relapse rates as mastectomy, and with fewer surgeries. Everyone can present beautiful results at conferences, but no one wants to show complications and bad results. Capsular contracture after radiotherapy, skin necrosis, infection, implant loss. Much more research supports the same conclusion. It's much better to do a partial reconstruction than a total mammary reconstruction whenever possible. We have participated in a consensus conference in Switzerland 2 years ago and published an article about total breast reconstruction in the setting of post-mastectomy radiation. And if there is really a consensus, is that breast reconstruction is much more difficult for surgeons or patients after radiotherapy. Surgery is much more complex, complications are more frequent, and usually require multiple procedures. For locally advanced tumors, we will need to refer to patients to radiotherapy anyway. That's another reason to prefer conservative treatment. I believe the only real limitation for a conservative treatment is our ability to leave behind a good cosmetic result and a good symmetry. These are some real patients that came to our service, referred by other surgeons for delayed reconstructions after a conservative treatment. Nobody wants to have such poor aesthetic results. The two main tools that we have available for increasing the indications of conservative treatments are neoadjuvant chemotherapy and oncoplastic surgery. Neoadjuvant chemotherapy is safe, it reduces the size of the tumor, increases the rates of conservative treatment, and reduces the reoperation rate due to positive margins. Oncoplasty would be a combination of oncology and mammoplasty. The term was first coined by Professor Werner Aldrich, a breast surgeon from Germany, with whom I had the opportunity to be many years ago. I also had the opportunity to learn from Professors Jean-Yves Petit and Mario Richens in Italy, some of the pioneers as well in this kind of surgery, oncoplastic surgery. We published this year a meta-analysis showing that we can obtain the same level of patient satisfaction with oncoplastic surgery, even operating on larger tumors. It's similar to conventional breast conserving surgery. Another meta-analysis published this year showed that oncoplastic surgery reduced complications in conservative surgery by reducing re-excisions, positive surgical margins, and mastectomy rates. When I was learning oncoplastic surgery, my masters taught me that by knowing these three techniques, we could solve more than 90% of the cases. A superior pedicle for tumors in the lower quadrants, an inferior pedicle for tumors in the upper quadrants, and a round block mammoplasty for breasts with limited pitosis. Otherwise, a mastectomy would be necessary. Actually, there are lots of different techniques. A very well-known classification for oncoplastic techniques is this one of volume displacement and volume replacement. For large breasts or small tumors, we may use a volume displacement technique, like a mammoplasty for example, and for small breasts without ptosis or for large tumors, we may replace the volume with tissues outside the breast. Here you can see some examples of thoracilateral flaps, thoracepigastric flaps. We can also use lipofilling, the perforated flaps. There are many possibilities of volume replacement technique as well. Something very important, it's better to plan a partial reconstruction in advance and do it immediately along with lumpectomy. Dr. Krishna Plouffe from France showed that if you must operate on irradiated breasts, the complication rate increases 3 times and the poor aesthetic results 4 times. In irradiated breasts, we try to avoid undermining. In some cases, I avoid operating at all. Usually we reposition the nipple to a more central position or make a small skin adjustment, revise large scars, and correct small retractions with fat grafting. If you need a mastectomy, the choice between a myocutaneous flap or implant is very personal. You will find people that will defend autologous reconstruction and others that prefer implants. In this huge meta-analysis, expanders and implants have 7 times the risk of total failure in comparison to flaps and 3 times the risk of infection. However, flaps are more complex, it takes more time, and they have 3 times a greater risk of necrosis. No difference were seen regarding hematoma, dehiscence, thrombosis, reoperation, and other complications. There was a large difference, however, in the case of radiotherapy. For radiated tissues, flaps were much safer. In the case of mastectomy, these are my preferable options. If I have the nipple or at least a good quality and enough skin envelope, I place a definitive implant at the same time. Sometimes I use the pectoralis muscle to cover the implant, but lately it's becoming more common to place the implant in the prepectoral plane. If we have enough subcutaneous tissue and there is a nice flap vitality. Otherwise, I place an expander and change it for an implant in the second step. I use mycutaneous flaps usually in the case of previous radiotherapy, like in this first example of local recurrence in which I used the latissimus dorsi. Some patients prefer a more complex surgery to have a more natural aspect of breast, like in the second example. And in cases of a very bad radiated tumor bed, a DAP or a trim flap would have some advantages. We can substitute most of the irradiated skin. Some people also take benefit of some improvement in the donor site. They get rid of the belly, although it isn't the same as in abdominoplasty. In some patients that have contraindications to these mycutaneous flaps or microsurgical reconstruction, we could also use lipofilling to make the tumor bed a little better, to renew it, and it will be more susceptible to accept the implant. Lipofilling is very useful, especially for the refinements, to fill some sinkings and retractions, for example, as in these cases. Nowadays, there is an epidemic of bilateral mastectomies. Some patients have pathogenic mutations that increase the risk of breast cancer. That was on the Angelina Jolie's case, but it isn't common. Less than 10% of the patients. Because of fear, some patients and doctors prefer to remove both breasts without mutations, even if a conservative surgery is adequate. This meta-analysis of 61 studies showed that 5 to 15% of patients are sorry with the decision of a bilateral mastectomy. 15 to 19% are dissatisfied with aesthetic results after 1 year, and it gets worse over time. 23 to 55% of the women think they look worse after surgery. 32% have psychological problems because of it. 23 to 45% experience a worsening in sexuality. 45% loss of sensitivity. 70% pain and discomfort. Additional non-planned surgeries are very often, especially in case of reconstructions. Women don't know it when they ask us to do a bilateral mastectomy. They act out of fear. They think it could prevent the tumor to recur. It's our obligation to explain that a conservative treatment is as safe as mastectomy in most cases, and that usually the difference is just more risk of complications. Another important part of breast cancer surgery is the axillary management. Axillary clearance has been the standard for many years, but it's been associated to many complications like seroma formation, lymphedema, paresthesia, pain, weakness, and shoulder restriction. Fortunately, things are changing. We are now in the era of sentinel node biopsies. For most of our patients, unless axilla is clearly involved, we may find the sentinel node using blue dye, radioactivity technician, and other methods. The sentinel node is the first group of lymph nodes that drain lymph from the breast. If sentinel node is free, usually the others will be. Even in the case of escaped metastasis, the risk of axillary recurrence is very low. Overall, around 1% in any circumstance. In the case of sentinel node biopsy or in the case of axillary clearance is the same. After the Z11 study, even if there is 1 or 2 positive lymph nodes after conservative treatments, the consensus is not to proceed to an axillary clearance. The cumulative axillary recurrence in 10 years will be only 1.5%. The exception is in the case of gross capsular extravasation. In that case, the recommendation is to dissect the axilla. After this study, there were other important studies like IBC-SG 2301 that prevented axillary dissection in the case of macrometastasis in the lymph nodes. INSEMA and SENOMAC validated the ECOSOG Z11 and included enough cases of mastectomy to prevent axillary clearance, also if the patients were submitted to mastectomy. After neoadjuvant chemotherapy, there is still a lot of controversy. If the lymph nodes was always clinically negative, it's considered to be safe. In the case of a positive node that become negative after chemotherapy, there's a high risk of a false negative result. Researchers are trying to reduce the false negatives, combining two methods like blue dye and technetium, resecting more lymph nodes, or marking the positive lymph node with a metal clip, radioactivity seed, or another method. As a matter of fact, axillary recurrence will be a rare event anyway. We organize a virtual hands-on course on oncoplastic surgery and breast reconstruction in Brazil with simultaneous translation into Portuguese, English, and Spanish with attendees from many countries. We perform together in this course around 100 live reconstructive procedures in 11 months, 2 days a month. There is the participation of great names of oncoplastic surgeries around the world. It's really possible to learn from the basics to the more advanced techniques. We need more people prepared to offer a good or excellent service to our patients. They deserve it. We are also organizing a cadaver lab in Orlando, in the United States, in November this year. It will be possible to participate. And that's it for today. I tried to bring together some important features of breast cancer surgical treatment and breast reconstruction to give you guys a general idea of breast cancer and also of the breast cancer treatment, especially breast cancer surgery. I hope it's been useful to you. And I would like to make you know this website, oncoplastic.com. I created this website at the beginning of the pandemic to help colleagues and alumni. And now there are thousands of colleagues around the world using the website. There are lots of different surgical video clips showing all the techniques of breast reconstruction, many classes. I will upload this class also to the site after if you want to see it again. Thank you very much for the opportunity to be here in Sweden with you. It was really a pleasure, and have a nice day.